Thank you very much, Pedro, and thank you to Francesca and also to Julio for the invitation and for organizing this meeting. I'm going to touch a little bit on the problems that we have from the healthcare workforce, and I'll start by saying that really the price of antiretrovirals has fallen, that really we're no longer talking about how do we pay for the drugs. I think the issue right now is how do we have the healthcare system that can deliver the drug, or how can we actually do what we're trying to accomplish. And I don't think it's any news to most of you is that there are major challenges in sub-Saharan Africa around healthcare workforce. And a lot of it's being talked about this crisis, but I think very little has been actually done about it. And I think we really need to focus much more of our efforts on this. So I love this maps. This is World Mapper. I use them a lot when I teach my class in global health. And this is the HIV prevalence in 15 to 49-year-olds by country. And you can see where the problem is. India is also a very big bulge here. But just keep that image in mind as we move to the next image. This is actually a proportion of physicians working in each country. And I think this really emphasizes that there's a huge mismatch for where the epidemic is and where the workforce is. The only country you can see, I always show this to my students, I say, what country is this? Well, this is Cuba, okay? But obviously you can see that we almost don't see Africa here because the workforce there is very, very limited. And if you go by the numbers, Africa, as you know, bears 24% of the global burden of HIV, yet it's really only 3% of the world's healthcare force, and less than 1% of the world financing resources for healthcare. This is not just HIV, this is healthcare in general. As I remind people, this is not just everything is fine and HIV is the problem. Everything is the problem. HIV is actually a little less than a problem than many other diseases. But you have areas where there's about, in summary, in sub-Saharan Africa, there are about 18 physicians per 100,000 populations. And in fact, there's 65,000 African-born physicians. That's about 20% of those ever trained who actually are no longer here. They have migrated to high-income countries within the past 5 years. And 1/3 of medical faculty positions at most universities are unfilled. So there are enormous priorities that we need to pay attention to as we think about workforce capacity. I think one of the most important ones that, again, we don't talk much about is we need to reduce the impact of the HIV and TB epidemics on the healthcare workforce. We need to make the work environment safer. We really need to pay more attention about people who are working, and this is not just universal precautions. This is preventing people from acquiring tuberculosis. We know what happened with Ebola. I mean, a lot of the people that died of Ebola were actually healthcare workers. If we don't have a safe work environment, it's very hard to ask people to work in that environment. And we need to really, again, frequently I hear, well, you need to get people to wash their hands. It's very hard to wash your hands if you don't have water. So there are very simple things that need to be done, and I think part of strengthening healthcare facilities really is looking about those simple things: water, sanitation, airflow, making sure that people are not transmitting TB within healthcare facilities. Number two, we've talked a lot about task shifting, and we'll continue to mention that. But when I hear about task shifting, I always worry about task shifting to whom? Well, who are we task shifting to? Who are those people? And at what point in time you simply need to train more people that you can task shift to? We have to scale up medical and nursing education. We need to strengthen primary health care, and we need to tackle the brain drain. So what about the medical schools in sub-Saharan Africa? Well, there is a huge problem of not having enough people trained and not having enough people remain. So a couple of things have happened, and one of them is, as I mentioned, the high level of immigration to other countries is really part of the issue. And very few of faculty in this medical schools that remain in Africa is involved in research. I mean, many of you here are, but the great majority are not. And part of the reason why people are not involved in research is because the pay scale to people working within academic institutions in sub-Saharan Africa for those physicians or those clinicians is so low that they have to have 2, 3, 4 jobs in order to make a living. So we need to change that. We really have to change that. Let me talk a little bit about medical and nursing education since I've been involved in those. MEPI is an initiative called the Medical Education Partnership Initiative. It involved 11 countries in sub-Saharan Africa. It was locally driven, and NEPI is pretty similar. It's a Nursing Education Partnership Initiative. This was an initiative that came out of really of the NIH, Francis Collins, Eric Gooseby, et cetera, working together as a partnership between PEPFAR, NIH, HRSA, to really transform medical education at selected schools in Africa, and was intended to provide a focus for U.S. agencies to support local health ministries and academic centers to improve the quality, quantity, and retention of their graduates and improve their research capabilities. And this program started in 2010. It has ended as in its first phase. MEPI has ended in its first phase, and really was overall, I would say, an incredible success. It created great partnerships between U.S. and African institutions that, at least in the one that I'm involved with Addis Ababa University in Ethiopia, has continued and has really created a great capacity building initiative that has gone on after the grant has ended. The long-term goal is obviously how do we continue this, and how do we ensure that we have enough people trained and dedicated to continue working not only in HIV, but in the increasing burden of non-communicable diseases that we're seeing in these countries. And I think a lot of the lessons from HIV will then be applied to many other diseases like diabetes, hypertension, just like initiatives like SEARCH have done. So this is, you really probably can't see it, but this is the countries and the US institutions and African institutions that partner in MEPI. I want to end just by talking about, again, a lot has been said about the community health worker. When we talk about task shifting, we frequently talk about the community health worker. And I love this image because basically everybody in every field, here we're talking about HIV, but if you go to TB, if you go to the nutrition group, every field says, oh, let's just task shift to the community health worker. And I worry that the community health worker has every single person is putting one more thing on top of their heads, and they're responsible to take into the field. And I think we need to be cognizant that that's not possible, and also that these people actually need to be paid for what they're doing. Many of these community health workers we're getting them to do things and not paying them to do it, and this is simply not acceptable. We need to make them part of the effort, and this needs to be a job. This doesn't need to be a volunteer service that everybody dumps whatever they want done onto them. So really what we need to talk about is more how do we build community capacity? How do we really, create a system in which the community actually gets involved, not just the community health worker, but what are the different resources that are needed at the community level to improve care, to provide better prevention interventions, et cetera. I want to end just by mentioning that something that is a very well-intended thing, I think, but in many institutions across the developed world, part of what they do is, we're going to help African institutions by sending equipment. And all of us that have gone to any hospital or any clinic in sub-Saharan Africa can open a door, and there is essentially junk equipment stored in there. And I want to emphasize, I want to please plea that people stop sending junk equipment to Africa. We really don't need junk equipment, okay? We have to stop. This is not helping. This is not donors. This is not doing good. This is actually harming and creating just more waste. And it's like we're throwing our waste somewhere else. So please stop that. This is not building capacity. And again, we really need to do it together. If we want to go far, we have to work together. So we should not just talk about task shifting, but we really should talk about how do we build teams, how do we build partnerships that last, and how do we really, at the end of the day, allow everybody to have access to health and to health equity that we all started asking for here in Durban, 16 years ago. It is time that we make that a reality. Thank you very much.